Hello, everyone. My name is Andrew Ushery. I am presenting MBA 7800, my first business presentation. I am actually a retired registered nurse. I've been a registered nurse for 16 years. I have lots of initials behind my name, and I've tried to weed out the ones that I don't think that are applicable. However, I put them there simply because I wanted everyone to know that I have an abstract way of thinking. I'm always trying to think outside of the box. So it's important to me, especially whenever it comes to healthcare cost, to get out of the mold and the way that we've been thinking as far as pulling at margins and, allowing different accreditation agencies, to have such a strong impact on us. So I'm going to give you a brief overview of who I am, and perhaps it will parlay into your understanding of the reason why I chose my article. I attended VSU. I'm actually an alumni of VSU. I got my BSN. I graduated in 2001. Worked as a nurse until 2016, and then I decided that I had to get a business degree. So it's owning your own business and also being a critical care nurse is, they're dichotomous in nature. Business and nursing, not the actual, perfect paradigm for any means, but I went to Harvard in 2005 for a year and got my critical care registered nurse certification, which really put me into a different playing field, to say the least. I was basically put into healthcare because whenever I was 15, my best friend at the time, her father had cancer, and the hospice nurses that came to the house, I knew immediately that I had to be a nurse. Absolutely had to be a nurse. Needless to say, I did not realize that you had to have 2 years of critical care nurse experience prior to being a hospice nurse. So my main focus in my entire healthcare career has been in critical care and trauma nursing. So I became a nurse manager of Emory Healthcare, which I think is an amazing facility, in the cardiovascular ICU. And that was in 2009. And then I went up for my promotion to get actually a higher level director position, and they told me that I had to have a master's degree. That was their protocol, hence I followed it. So I moved from Atlanta back to Valdosta to get my BBA in order to get my MBA, because you can't go from a science bachelor's degree to a business degree. So I had to take the appropriate processes. So my life passion is healthcare. I've devoted everything that I have, all of my resources, to healthcare. There's nothing more important to me than healthcare. I believe that the quality of care and just process improvements has not only been what has sustained healthcare, but is what's going to be in our future. Things that we have to focus on. It's cost driven, and I think there's so many articles and so much publicity about the cost of healthcare, of course it being 17.6% of our GDP. But what about our quality? Where did our quality and our costs seem not to have ever intercepted, except for on a negative balance? Of course, a very strong concern, being that I own my own business in healthcare, is just this continual rise in the elevation of healthcare. And of course, I'm very committed to community health. It is just as strong as running a hospital or being any sort of healthcare administrator. To be involved in your community is to be involved in healthcare. I sit on several boards. One that I'm utmost passionate about is being the board of directors for the Alzheimer's Caregiver. It's a nonprofit, one of the most rewarding positions that I've ever had. I will never get rich from it. However, I will personally be enriched. I'm also a member of the American College of Healthcare Executives. I started out as a student associate, and my article actually comes from the American College of Healthcare Executives magazine, which I get once every 2 months. And it's a wealth of information. I strongly encourage you to look at my citations at the end, and please click on the link so you can find out more. It is an invaluable resource. And then, as far as Valdosta State University is concerned, I'm the graduate vice president of the Institute of Healthcare Improvement, and I'm currently working on a process improvement project with them to represent the state of Georgia. And last but not least, I had to obtain a master's degree simply because I could not progress in administration, excuse me, without a higher level of education. And you would think with being a nurse manager and being in the trenches that you would not have to have a master's degree. However, now I see the significance of having a business degree in healthcare administration instead of just looking through an Outlook as a registered nurse. And that brings me to my target audience. And this is my healthcare university. The University of Utah healthcare system is quite unprecedented. I really did not understand, nor did I realize the magnitude of the things that they were actually doing in Utah. I'm not really one to say that I would swap universities or swap a healthcare organization, but whenever you find out what someone is truly passionate about and it goes along directly with how you feel, then you start thinking to yourself, okay, is this exactly where I want to be? Is this what I'm going to do with my education? So, saying that, I also wanted to play you this recording. I tried to break it down. However, it was simply best left said by the following.
Hello, I'm Dr. Vivian Lee. As the only academic medical center in the Intermountain West, University of Utah Healthcare is committed to its mission of providing compassionate care, conducting innovative research, and educating the next generation of health professionals. Our system has a long and rich history, from humble origins as an upstart medical school in 1905 to our reputation today as one of the country's top health systems. Our success lies in our ability to recruit the best and brightest minds in science and medicine. On behalf of the remarkable faculty, students, and staff who make up University of Utah Healthcare, I am pleased to affirm our commitment to the community we serve.
University of Utah Healthcare includes 4 hospitals: University Hospital, Huntsman Cancer Hospital, the University Orthopedic Center, and the University Neuropsychiatric Institute. We also have neighborhood health clinics, including a multi-specialty and surgery center in South Jordan. Throughout our system, more than 1,000 physicians, representing 200 medical specialties, help treat more than 1 million patients each year. Our colleges of nursing, pharmacy, and health are nationally ranked, and our researchers are taking part each day in breakthroughs that provide better treatments and cures for disease. We weren't always as big as we are today. It all started in 1905. The Hughes Medical School trained 6 students and operated on a budget of $10,000 a year. But despite how small it was, the University of Utah was quickly recognized as a center of excellence. It became known as the Johns Hopkins of the West. In 1965, the first incarnation of University Hospital opened. In 1981, the hospital was expanded to increase the capacity of the emergency department, as well as the intensive care units and operating rooms. In 2009, another expansion marked a new era for University of Utah healthcare. Today, the hospital's reputation, the excellence of our academic colleges, and cutting-edge research has led to major medical breakthroughs. For the past 2 decades, U.S. News & World Report has ranked us as one of the top hospital systems in the country. We've also been ranked as one of the top academic medical centers in the country by the prestigious University Health System Consortium. Yet, our world-class technology, facilities, research, and education are simply tools in the hands of each of us who care for patients. Just like in 1905, University of Utah Healthcare continues to attract the best people. And that's the real story behind our tradition of excellence. While we entered the 20th century as an upstart medical school, today we continue as one of the best healthcare systems in the nation. And our core mission is always at the forefront of everything we do. Excellent patient care, education, and research.
So that just goes into what an amazing facility that they've started. So there's different things that I just wanted to point out about the University of Utah Healthcare is they've got so many milestones that they have accomplished. 1912, the AMA, the American Association of Medical Schools. Amazing. I mean, they're the frontiers. And then they clinically appointed physicians as teachers, which was unprecedented at that time. And then you have the 4-year medical school was officially accredited in 1944. They are literally on the forefront of healthcare. Who would have ever known like a Midwestern state would be so advanced? I certainly didn't. And then in 1948, they were granted a cancer research, which at the time was not that big of an issue, but $416,000 whenever you factor in cost of inflation, and time value of money, $416,000 is well over $1 million as we know it today. The U.S. Public Services, also tying into our material, gave them $1.5 million for research. In 1955, our deficit at that point was almost equivalent. So I really, whenever I was reading this article, I did not understand how no one has heard of the University of Utah, which is why I wanted to bring this out, because it's so much of a cost containment issue as much as it is anything else. And then we had them, they open a brand new hospital, 222 beds. I live in Valdosta. Our maximum capacity at South Georgia Medical Center is 210 beds. So how in 1965 did they have a larger hospital base than what we currently have? I mean, these are unprecedented milestones. Once again, Utah opens up another hospital, $43 million. Time value of money says that's $70 million. And in 1981, once again, unprecedented amounts of money. So then they decided to integrate their system, consolidation and utilization. So then they created a network of 14 subsidiaries, making them the largest healthcare system in the Midwest. Extremely important. As I progressed, they opened up a critical care pavilion, which, as a healthcare administration, that is our biggest income as far as our revenue cycle is critical care. You have to have very highly trained nurses, physician, allied health, all to make a pavilion of this nature. Who knew? Once again. Okay, so here we find it again, 2008. They were awarded $22.5 million just for research. That is, upon my research, the highest paid award from the National Institute of Healthcare that has ever been given. And it was given to this university based upon their ability to research and give quality outcomes. 2009, 1 year later, they opened another $200 million care pavilion. These pavilions are not, well, I think I need to give a demonstration of a pavilion. It is an all-encompassing way, it's a holistic care of your patient. And then, of course, we all know that family is also considered inpatient care. So there is a place to eat, they have rooms, almost like a hotel room. They have cafeterias. It's almost like one of those things that you get whenever you go to a high-end hotel. But that is how they marketed themselves in order to increase revenue cycles. And the most important thing, which is what my presentation is on, is they were the creators and the pioneers for a value-driven outcome. They developed a tool, which is commonly known as the VDO, which up until my research, I did not realize was so important. So once again, they're constantly on the edge of making cost, value, and quality measure improvements. So just to talk a little bit more about the University of Utah, I don't want to overdo it, but at the same time, they're 6 years running as one of the number one healthcare systems. And they did not do that by running into the red. Whenever it comes to stakeholders, return on investments, no one has done it quite like they have. And it's because of their implementation processes and knowing where they're going to go with the decrease in revenue coming from, the center, from Medicaid, Medicare services, quality-based reinforcement. It's all value-based driven. However, their primary concern is quality and value. And being a registered nurse, that is my most important aspect. Well, let me digress for just one moment. I never thought, whenever I first started nursing, that cost had anything to do with the quality. However, now I know with DRGs and capitation and fee for service, you just can't do the things that you used to be able to do. We have unlimited resources as long as we gave the best care, which is the value and the quality. And now we're seeing that the value and the quality of the care is actually how we're getting reimbursed. Whether you're a magnet hospital, you meet a certain qualification, certificate of need, you get a higher reimbursement. However, you cannot take from the margins, you have to have it from the inside out. So, my article is about revealing the secret to sustainable healthcare: cost savings. And the reason why I say cost savings, whenever you go to Google and you type in healthcare, whether it's Yahoo or Bing, you type in healthcare, it automatically populates cost. And this, once again, came from the Healthcare Executive magazine. A wonderful article. I encourage everyone to read it. And then I've cited a lot of different resources to look at, so I strongly encourage that as well. So it's the way that they addressed this issue is basic scientific method. Like, you got to identify the problem, and then you have to come up with what you think is a solution. Then you have to implement it, and then you just continue down the process. As easy as that says, or sounds, I should say, in healthcare, it's somewhat dichotomous in nature in itself. So the University of Utah has developed this new system. It's called the VDO, the Value Driven Outcomes. And they take data and put it into protocols, and then they do 90-day evaluations and implementations. It's actually resulted in great cost savings. So they're no longer dependent upon running their hospital into the red, because they're internally reducing expenditures and decreasing excuse me, and decreasing the amount of revenue that's expendable. So the VDO, Value Driven Outcomes, is basically like a consolidation and an integration. So it's taking what we have and then looking upon how we can implement the two together. Let's consolidate our resources, and then let's integrate things that we can do as an organization instead of waiting for an outside entity, such as a third-party payer, to produce our revenue. And most importantly, and this is really, my primary focus, is the quality of care. And we know as an economy, our cost driver is cost. It's all about cost. But we cannot give up on quality patient care no matter what. We cannot worry about our cost. So this is why I chose this article once again, because it's an internal structure. It's an internal way of reducing healthcare costs within that organization without having to worry about the ACA and the CMS. So there's this Harvard Business Review in 2011, Michael Porter, he said, we've been talking about cost containment in healthcare, and it's been a ridiculous long time, and nothing has been solved. And whenever you look at statistics within various organizations, we all know this to be the truth. We cannot contain healthcare costs. It seems literally almost impossible. However, in my article and doing further research upon my article, they broke it down into a system of steps. And the first one was start with the clinical information. Cost data, outcomes data, all of this goes into a mainframe of the computer system. Documentation, and they are able to see the cost and then they can see the outcomes, hence the VDO, value driven outcomes. And then you can look at step 2, focus on the process variation, quality variation indicators. If we do this, what is our outcome? If we don't do this, what is our outcome? If we implement this protocol, what is the cost? Once again, it all comes down to healthcare cost savings. So what the University of Utah has done is actually done 90-day projects. They do it quarterly, so there's 4 per year. And I've got some great things to show you guys to kind of let you see my aspect on the 90-day projects. And then, of course, we've got step 3. And this, in my opinion, of course, are the challenges. There's many people that think that, hey, it's a challenge, it's an obstacle. We've got to overcome it. Well, yeah, we do. It's a challenge, but it's nothing that as healthcare administrators that we cannot address. So there was a multitude of resources that I pulled from, once again in my citations, and this is what it is. Service and cost. How do you balance that? What's the quality? We all know if you're getting paid $50 an hour versus $20 an hour, you're going to absolutely give your best. Well, in theory, at least. And then you zero in on your top priorities. What's the strategy? Where are we going to hit this from? How are we going to target our stakeholders' priorities versus our patient quality? And then you have to benchmark your cost, which is extremely hard to do whenever there's not been a system in place prior to this value-driven outcome system, which is the VDO. And then, of course, there's practicing at the top of the license. And I could not agree more with this simply because as a CCRN, you do make a higher wage because you're highly credentialed. As a physician, if you're a specialist, you should be used in that capacity and in that capacity alone. You do not take someone that is well educated and give them a job to do that someone else at a lower pay can do. That is cost savings. Once again, whenever you have an institution or a healthcare system, an organization that has a various side of care, whether it be outpatient service, inpatient service, being a specialty, it doesn't really matter. You're not going to congest your main hospital and charge at a higher price whenever the revenue cycle is completely going to change if you do it at an outpatient facility. So these things have got to be addressed. However, there are challenges with it as far as getting everyone on board, but it's not something that we cannot do. And these are the things that we have to think about. And most importantly, we have got to have a consistent level of care. Once we start something, we can't stop it. So to implement such protocols and policies and procedures and guidelines, even job descriptions, to continue the care of a patient, whether it's referring them to a different specialty, even if it's going out of network for you, is it cheaper? Are they going to get better care? This, in my opinion, is substantial. Oh, and last but not least, meeting the cost savings challenge. Well, there's a huge risk whenever it comes to value-based payment. We all know the ACA, we all know the CMS. I mean, we are literally being forced to rethink everything. Everything from a business cycle to a revenue cycle to stakeholders, non-for-profit, for-profit. It is a business. Healthcare is a business. As unfortunate as it seems, that is the way that it goes. But our highest priority has got to be clinical care. And it's meeting these cost-saving challenges that is actually going to save our industry. So I thought this very applicable, the VDO scorecard. So the VDO, of course, is value-driven outcomes, and this is the metrics that they have used. As I use my mouse here, we start at 20% of perfect care, which I don't exactly agree in perfect care because everyone is an individual. There's no such thing as perfect. And as you follow it down, this completely reflects a business cycle. Once again, healthcare is a business. So they implemented, as you see, a congruency and a parallelism, and then they implemented these protocols Q2 2015, and then you look, perfect care dropped significantly. And then you see a spike in the mean cost per patient. I mean, these are direct statistic results that show that their VDO system is actually working. It is showing that they have saved $40 million in their last quarter. And then, as a normal business cycle would be, it comes out. So we're starting to meet the margin. Our coefficient variance is very small whenever you look at the fourth quarter. So in saying that, that's okay. Perfect care is achieved if we have these protocols set in place. These go from medications, from nurses' responsibilities to especially administration, because we have to have these policies and procedures and these protocols in order for there to be an optimal outcome. Or else, you can see what happened. It's right there in front of your face. I do, however, see some problems. So, with an organization that can house over 12,000 patients, in order to get system data and outcomes data, you've got to have a significant increase in information technology. One thing the VDO system does not do is computate the administration cost overhead. So it kind of makes it a little top heavy. So you really have to worry about, okay, am I making an initial investment that is going to overall improve my organization? But if you don't have a large enough organization, how is it possibly going to work? And once again, that goes against their business model, against their mission statement. Of course, they want to give quality health care, but when all of their overhead is going to technology, we are once again forgetting the quality and the value of our patient. So, one of the things that I found very interesting was pulling at the margins, reducing overhead, decreasing the supply expenditure. Well, we've been doing that for the last 20, 30 years. We have gotten nowhere. It's actually breaking down the cost of the patient. Like, what does this patient need? How much is it going to cost us? And then involving all clinician care to say, okay, we can do this better by evidence-based practices. We can look at the different models that come from, our accreditations and see where we can give a little bit. And then the fact that the value-driven outcome tool, actually gives a breakdown of cost versus outcome, which was my previous slide. However, I still think there is a potential for increased technology and decreased bedside direct care, which is how we're getting paid. So the higher the magnitude of the hospital, the more reimbursement you're going to get. Second problem, well, I say problem, I mean potential problem, is the resistance from your staff. They implement every 90 days a new implementation. This is what we've learned from our VDO system. So we're changing the policies, we're changing the procedures. There's more input going to be needed per the clinician, whether it be a physician, allied health, to satisfy accreditations from, the government, CMS, it really does not matter. But whenever you're more focused upon inputting data for this system to work, what happens to your bedside care? Are you more focused on inputting data than you are actually taking care of your patient? That is something that I would definitely keep my eye on. However, because the University of Utah is a magnet hospital, they do get an increased reimbursement from all third-party payers. And then you also have to think, like, what is your required performance? What is actually in your job title? So if you're changing and implementing something every 90 days, is your job description changing every 90 days? Is there any incentive? It makes you wonder. However, I think that the University of Utah have done a wonderful job with increasing employee satisfaction. They have wellness programs, which the majority of hospitals do. They give their employees Fitbits, which is, goes around the wrist. I'm a little older, so it's kind of different for me. However, like, it monitors your heart rate. It monitors so many different things, which is then input into a system. Is that correct or incorrect? Who really knows at this point? But if you sign up for it and sign a waiver, it doesn't matter. There's no legality. They give free memberships. If you're sick, you don't even have to go to your primary physician. You can go straight into your job for preventative health care. You can even bring your family members free of charge. We know that 80% of the nursing workforce have children. They're women. They have free in-house daycare. There's a dietitian also. She can refer you to a cafeteria plan whenever you're at work. Once again, just incentivizing your employee to want to be part of your organization. I understand that some people just need a job, but whenever you run a magnet hospital that have 14 subsidiaries, you need to focus on what is keeping them happy. What is the price of hiring someone new, retraining? And we talk about cost. Well, there's your cost. And then once again, you're another potential problem. Basing your cost decision and integrating your value. Could that lead to poor outcomes? If you have to take care of your patient, but also know that you have an added stress upon documentation, which one comes first? Well, the rule of thumb, in my opinion, and the opinions of multiple other healthcare systems, is you take care of the patient and not a number. So I think that the University of Utah does a fairly good job with that. I think perhaps they could do it a little stronger. Once again, that's a personal opinion. But a strongly educated staff, once you've got a level of expertise, it doesn't matter. You want to be part of that organization. That is organizational culture. And then by separating the information with the value driven outcomes from administration to the bedside nurse will actually less the pressure on the healthcare giver. Instead of it being about numbers, just let that be in administration and let them perform the essential bedside care that they need to do. And administration, they need the numbers. They are the ones that write policies and procedures. They are the ones that take it to the board. It is not direct patient contacts that can come up with these policies and procedures. And ultimately, visible improved outcomes make a positive impact, not only on the employee, but on the patient. Patients can see everything that you're doing from the time you walk in the door, from the time that they leave. They don't care that we've got a value-driven outcome system. They only care that they got quality care. And my last point, as far as potential problems, is how are we going to benchmark? Well, we can't, because this VDO system is only within the University of Utah and Yale New Haven campus. So you have two different variables there. I mean, is this going to be something that's a core competency, like a comparative advantage? Or is it simply going to be something that they're doing better than the rest of us because we cannot institute this type or afford this type of information technology? I mean, these are things that we have to think about. So, one thing that I did learn about the University of Utah, knowing that their benchmarking process was a problem, is they have invited several other healthcare organizations into the process, giving them the VDO approach. So instead of benchmarking with two facilities, it's spreading out so we can actually see and actually contain these costs. Sustainability healthcare cost. My entire presentation. So to increase the usage, yes, is going to require a higher level of information technology, but overall, to decrease the healthcare expense in a quarterly income in $40 million, I think my mom once told me that you have to spend money to make money. Yeah, I think that that's very applicable here as well. And then I think as far as whenever it comes to competitors, just decreasing the total cost of healthcare Even if you do it just one hospital at the time, implement this benchmarking system so you can learn how to internalize cost. It would just. So, as far as the questions that I would ask my employer, and I put this on the bottom of the list because this would be literally like the last thing that I would probably ask, but I still think it's relevant. Are the employees incentivized to thoroughly document in a new data system? We've had EHRs. I started nursing and it was all done. You wrote everything down. And as EHRs developed, your patient did suffer because you had to click on this, and it was firewalled. You could not progress without filling in, the information that was required by the center. And then you got docked. Like, whenever it come up for your evaluation, it was, well, you missed these critical areas. Is there some sort of way that we can go around incentivizing and just make it part of the standard? And then once again, it's like, how do you measure a patient's care instead of a cost per department? You have specialty areas that cancer, especially a research department, multiple sclerosis, autoimmune disorders. How do you measure that exactly? Well, the VDO system does not account for the total patient overhead. So how exactly does that work? That would be something that I would ask, especially being an administrator. And then you have to think upon these implementation of processes. Like, what is the resistance level? How many nurses have quit since you have started? How many physicians have decided to go somewhere else? Look at your allied staff. Look at your macro environment. Every 90 days to have to change what you've always known to be the same seems as if that would raise a lot of red flags. And before I think I would sign on for a hospital of this magnitude, exactly what has happened in the past. Was it a mass exodus, or was it something that people felt empowered by? And then once again, like, is there a system like of checks and balances? Like, you can only give someone, even administration, a certain level of responsibility. Is there someone that's overseeing the other, making sure that it's all equivalent? Excuse me, equivalent. And how does that actually ensure the quality and the accuracy of our data? Clearly, it's working, but is there a system of balance? And then once again, and this, I think I've said this several times already, but I really want to focus in on this because is it actually going to reduce the patient care? We've got so many variables and so much data entry in order for the system to work. Are we more concentrated on the data, or are we actually listening to our patients, taking care of our patients, instead of it being an algorithm of cost savings? We have to know that. I personally do not want to be part of a facility that is all data documented and our patients are suffering. That's not going to be me. And then, of course, You got to think, okay, what if I do a wonderful job? I'm Generation Y, I'm Generation X. However, I can do all of it at the same time, which many people can, but there are some people that fall through the cracks. So, is there some sort of incentive of saying, okay, you've got 100% documentation, so therefore you move up to another level, perhaps making them a super user, incentivizing them, which actually goes back to two bullets up by making these protocols, procedures, and policies necessary. Like, is it going to take away from the patient? Once again, as an administrator, I would like to bring up, the cost of new staffing. To introduce someone to such a vast healthcare system with so many implementations currently going on, knowing that by the time that they're trained within 30 days, which is statistically proven that we train healthcare personnel within 30 days, how is that going to impact our cost? How about our nurses, our physicians, once again, our allied health, our ancillary staff? We have to retrain them. Where is that money going to come? Is that going to be an overhead expense? Is that something that our stakeholders should be aware of before we implement such a process? And then, once again, like, how do you benchmark your decreasing costs whenever you're a massive organization, knowing that you could buy and sell another hospital with a blink of an eye? Not to be cliche, but I think that, that was addressed earlier with the potential problems. But it parlays also into a question that I would ask. Like, how are we better? What is our competitive advantage? Just because we have this system, nobody else does, so what are we basing it on? And then, of course, it's a competition. Like, you only are going to seek healthcare and something that you feel comfortable with, knowing that you're going to a magnet hospital, that once you get into their healthcare system, all basis of integumentary, neurology, GI, GU, orthopedics, cancer, research, all of that is going to be encompassed. Is that what is going to give us the upper hand in our competition when there are other places that have the same services? So I think the video does a very strong job as far as a value-driven outcome. However, is it really that effective? And how can we compare it to anyone else? And then last but not least, and I say this personally, but you've always heard of a organization, a healthcare system being top heavy. There's so many chiefs and very little Indians. Well, the Indians do the work. So whenever you implement such a powerful system, a data outcome system, and you're spending millions of dollars, how do your employees feel about that? Like, are you an administrative organization, or are you actually focusing upon the value and the quality? Yeah, it sounds great because you have such a powerful administration, but where are the people that are actually doing the work? So it does become a top-heavy institution, and that is something that I would like to know before I sign up. So here are my citations. I've actually got 2 pages. I really would encourage you guys to look at some of the data. I only had 30 minutes to speak, or else I probably could give an entire class on it. But please take some time and look into the different resources that I've pulled from. And I appreciate your attention, and thanks for watching.